Good morning, good afternoon, good evening from wherever you're joining us from. Welcome to the Testing Still Matters webinar. My name is Jacob Magero from Africa Health Business, and I'll be taking you through the session guidelines and program before introducing the moderator for the session. Attendees will be on mute during the session. Speakers are requested to observe the allocated time during their submission, and attendees are encouraged to type in their questions in the Q&A section, and they will be responded to as much as possible. You are also encouraged to tweet during the session using the hashtag COVID-19 and Diagnostics. On your screens, you have the program for the day. And at this juncture, I would like to introduce the moderator for the day. He is a renowned figure in the African health sector space and the executive chairman of Africa Health Business. Welcome, Dr. Amit N. Thaka.
Thank you, Jacob, and thank you for that introduction. We have started right on time. Let me also welcome this esteemed panelist that we have from across Africa. Let me also welcome all the attendees who joined in from Africa and beyond to discuss a topic. Testing still matters. Everyone is talking about vaccines and are rushing towards herd immunity. And all these strategies and news that we hear have had what you call the vaccine flavor. But the team here are going to talk about something that truly matters and will continue to matter for years to come, and that is testing. I am delighted that I'm joined by 5 panelists with all diverse qualifications and responsibilities, ranging from Africa CDC to Africa Society of Laboratory Medicine, to the Kenya Medical Research Institute, Lumira DX, and Pathcare Kenya, a good mix between the public and private sector as well. Let me just say, based on the agenda, we'll give each panelist between 8 to 10 minutes. We'll make a good circuit of the 5 panelists. It's a 90-minute session, as Jacob mentioned. We will leave a lot of time for Q&A and a dialogue before we have a closing session, and we'll end in 90 minutes from there. So we will spend the next 50 to 60 minutes with the panelists. It's a pleasure to actually have Dr. Benjamin Jodolbaye, who is the head of policy, health diplomacy, and communication at Africa CDC. Benjamin has also been in the forefront of continental strategy. So let me welcome Benjamin with 2 questions and invite him to stage. One thing that we would like you to share with us is the COVID-19 antigen strategy for Africa. We know that there were only 2 countries, I think, that had anything to do with PCR testing when the pandemic hit the continent. We've done very well. Congratulations to CDC and its team. We are now at a stage where we want to talk about what are the antigen testing strategies that you are encouraging your member states with. And when you answer that, just remember that PCR is still a challenge in terms of affordability, accessibility. And I think people are, finding it also inconvenient. Many of us have had those plenty of oral and nasal swabs, and we've had to wait for that result to hit in our inbox so that we can board the flight. And many passengers have been told that this is not even working. So how should we make it easier with maybe point of care testing and allow us free movement of goods, services, and people? So please welcome Dr. Benjamin onto the stage. The podium is yours, Dr. Benjamin.
Thank you very much, Amit. Thank you very much for associating Africa CDC and myself to this webinar, Testing Still Matters. This is a very timely webinar, as you rightly mentioned during your introductory remark, that everybody is talking about the vaccine and we seem to forget about testing. 2 key messages before I go into the 2 questions that you asked. First message is that testing is a key first-line defense against COVID-19 that enables early identification and isolation of cases to slow transmission and enhanced provision of targeted care to those infected while continuing with other vital healthcare services. So that is the key message number one. The key message number two is that testing is also key to successful delivery of COVID-19 vaccines. That is extremely important. Now, coming back to the strategy, the overarching strategy of COVID-19 antigen testing, to address the challenges of testing and to reduce COVID-19 transmission on the continent, Africa CDC last year, around April, same time, launched what we call the Partnership to Accelerate COVID-19 Testing, called PACT Initiative. And this is anchored to the three main goals of the African Union Joint Continental Strategy for COVID-19 response. With the objective one is preventing transmission, the second is the preventing death, and the third is minimizing the social and economic harms. And the PACT reveal the true burden and the scope of the disease, heighten the necessary public health and social measures for early containment and control of the pandemic. So that was what the strategy that exists at the continental level, which now the antigen, the rapid antigen testing is now part of this strategy. So what PACT did till date is to mobilize community workers, supplies, and other resources to accelerate case finding, increase targeted testing, and also to support care and treatment of identified cases. And from January 2020, you mentioned it also during your remarks, that there was no diagnostic capability at all on the continent, right? And in February, only 2 countries had the diagnostic capability, and these are Senegal and South Africa. In August, Africa CDC helped train more than 1,000 lab people and deployed more than 5 million tests and supplies in the member states. And 15 million tests were conducted on the continent. This was in August. In September, the antigen test started coming out, and it has been really embedded into our strategy. And we know, I'm linking now it to the second question that you asked. Yes, we know that the PCR tests remain the gold standard, but to date, we have more than 4 million antigen tests that have been distributed to all 55 AU member states. So the antigen tests have been embedded into our continental strategy. And we need to stand testing in African countries, especially considering the experience that India is going through currently, and the prevalence of the variants. That is extremely important. We know all the advantages of the rapid antigen test. First of all, is the turnout time in minutes compared to 4 to sometimes 24 hours, for PCR. Anyone can use it. Anyone can use it, and the cost is also another advantage. And okay, the challenge is accuracy that is moderate. And the other advantage, in order to help our countries to enable free movement of people, services, and and goods, we need to deploy this antigen test at the borders to open things, and it doesn't need really big infrastructure in place. What we should remember is that the testing value chain includes equipment, materials, ingredients such as reagents, PPEs. When expanding the testing, also we need to consider that one. It is extremely important. And we need to put focus on strengthening testing capacity and scaling testing for the medium to the long term, because this COVID is here with us and we don't know when it will go. So antigen tests is today a marvelous, let me put it that way, tool that will help us expand the diagnostic capability on the continent, since we cannot deploy PCR tests everywhere. So thank you very much. Let me stop there and give you back the floor. Thank you.
I'm going to really take you on that strategy. It's real good news, and I'm sure the panelists will talk about some challenges as we get to antigen testing. Benjamin, I'll be coming back to you to actually find out, will people in Africa get, relief from these long drawn out affairs? And I'm really pleased to hear about the 4 million and the 52 member states who've benefited from it. I think it's a nice time to bring Ndlovu Nkobile, who is the CEO at the African Society of Laboratory Medicine. And I think, Nkobile, your organization has been in the forefront in ensuring quality. And many people who are listening to us just don't want quality matters to be affecting them. So I want to bring you in on how will the quality of testing not be compromised when it comes to the COVID-19 testing. And when we talk about manufacturers, at one point we were bombarded in Africa with all sorts of people trying to bring antigen tests of all kinds. And when we talk about the private sector manufacturers, what message should we give them? Because many of them have logged in on how to introduce this to the market. And then it's the second point I want you to talk about is your view about public-private partnership. During pandemics, ministries of health, rightly so, want to have a controlled model in country to ensure that the right test at the right price is being done by the right people to get the right result. So please welcome Ndlovu Nkobile on stage to give us his views as the CEO of ASLM. Ndlovu, over to you.
Thank you so much, Dr. Amit, even for inviting me to this webinar. On behalf of the African Society for Laboratory Medicine, ASLM, I'm really excited to be here having this conversation, looking at that testing still matters. So really, I think all of us remembers that during the early days, there was much concern about making tests available, especially for the low middle income countries at a price point that was sustainable. And also there was concern about the ability to make enough tests that even the low and middle income countries will be able to access. We saw the issues of shutting down of borders even affecting the supply. But I'm happy today that the private sector really responded, and they brought in their skills, they brought in their expertise to the table immediately, even for the benefit of the low and middle income countries, including even Africa. And I'm so excited that they still announced access pricing, allocated volumes for the low middle income countries, and invested training. And we know that the PCR testing is the gold standard, but we were very excited at SLM that in addition to the PCR, they began to introduce and produce SARS-CoV-19 antigen rapid test that produced timely results within 30 minutes. And also they came with options even to use different sample types like swabs, like the nasal and the pharyngeal nasal swab. So there's been a lot that has come into the market, and I really want to appreciate the response that the private sector did. And one of the things that was very critical, especially at the start, was that these products had to be given emergency approval by WHO, and that really ensured that we are going to be using quality products. And as ASLM, we have been promoting those products that have been given emergency approval by WHO so that countries can use them. So just three things I want to mention quickly in terms of how the private sector has responded. Number one, they have developed the innovative diagnostics, especially when it comes to the introduction of rapid antigen tests into the market. And we all know that these antigen tests have been a game changer as they are provided at a lower cost and they're more flexible. They can be deployed to testing programs in a decentralized settings such as health facilities, communities, and even to reach some vulnerable populations and other settings for effective epidemic control. And the beauty of this is that they can be used outside the laboratories. And secondly, following the approval, the stringent approval of some of these products by WHO, you are right to say that the market was bombarded by a lot of these products, but I would like to appreciate the role that WHO through the PQ program are doing to really make sure that these products that are reaching our countries are of quality standard. But in addition to that, there's also been a lot of information that has been shared by the private sector, the manufacturers, including training, and SLM really has played a very important role to really support the quality of these products by making access to training on these products. So we have featured a number of websites as early as last year in terms of all the rapid antigen tests that were coming into the market. Number one, we wanted to know what are these? Have they gone through the emergency approval by WHO? What is the evidence that is there to make sure that they are of quality? How can countries use this even on the bench? So we made sure that that training is available, that information is available as part of a strategy to ensure that the testing that will ensure after that is of quality. And some of these videos are available even in our SLM YouTube videos. And lastly, I really want to appreciate even the role that they played in really mobilizing resources. I know that as early as last year, His Excellency, the former chair of AU, Cyril Ramaphosa, even appointed Strive Masiwa, who's the executive chair and founder of Econet, who really played a role. I mean, he's from the private sector, but played a role in mobilizing a lot of resources. Now, coming to the public-private partnership when it comes to PCR and antigen testing for COVID, I think it's important to know that the COVID pandemic is historic and it's unprecedented. And really, these are desperate times. And these will require everyone to renew our thinking and begin to work together collectively for us to realize the benefits of public-private partnerships. And I think there are a few things that I want to highlight here. Number one, the issue of healthy corporations and trust. So that still needs to be nurtured very well. Number two, the issues of sustainability and having resilient systems. I believe that countries should begin to learn and begin to see how they can optimize private sector healthcare solutions that are sustainable and resilient and informed by best practices, good governance, transparency, and fiscal sustainability to ensure continuity of services. And also, as COVID, we began to learn a lot, and I believe that these public-private partnership also should serve the issue around diagnostic integration. To allow for multiple disease testing and services approach. We know that many of these instruments are capable of testing other diseases like TB and HIV, and including COVID testing. So it will be very important that that discussion continues so that we can see how we can integrate COVID-19 into routine testing services, even at subnational levels. So let me stop here for now, Dr. Amit, over to you.
Thank you, Nkobile. I think your message is clear. I do want to echo your words about AMSP. I want to also recognize the presence of Uche from the Africa Medical Supplies Platform. Total respects for the South African president and Strive Masiva to also create this unique platform. We've engaged with them before. Your PPP views on trust, governance, fiscal responsibility and diagnostic integration are clear. We are coming back to you to actually talk a little bit more about WHO and stringent regulations when we circle back on where and how high the bar should be for Africa. But I think it nicely segues to the next panelists we have, who are both from public and private sector. Professor Matilu will be our next panelist. And you know, Professor Matilu is literally one of the champions in Kenya. And many accolades were given to what Kenya did during its early outbreak. And thanks to champions like you from KEMRI, who are advisors to the Minister for Health, I was personally witnessing your structured engagement. I want to jump into this space now. I know what you did was you started PCR with government laboratories like yours, and then we opened up to the private sector, and we have managed to do 1/3, I guess, of the tests coming from private sector. Pretty good. South Africa also has got some amazing numbers. Now, when we're doing point of care testing, Professor Matilu, and with the advent of these new variants coming in, and by the time we start approving these nice POC tests and these multiple double variants, India variants, whatever, what should we be concerned about? Maybe touch a little bit on that. And the second one is we want to accelerate easier, effective methodologies for 19 testing. To be honest, we've had this conversation. Many people on the call will tell you it's cumbersome, PCR takes long, and by the way, it's expensive. What can KEMRI do to accelerate these effective methodologies so that we can have free movement of goods, labor, and services? So please welcome Professor Matilu Mwao on the podium to address this gathering. Prof.
Thank you very much, Amit. Thank you. In fact, I'm quite happy that you followed up so that I could participate in this session. I've been itching to, bring into play some of the lessons that we are learning. It has been a year since this pandemic began. And I would want to start by saying that testing matters now even more than it did in the past, especially now that we are getting variants that are challenging us, and we are thinking very hard about how to restore our lives to something close to normal. People want to travel, people want to go back to their homes, people want to cross borders, people want to trade, and without testing, we think that this is not very possible because we want to continue to prevent the spread. As you know, we might spread even variants that can kill people, okay?
Yeah.
But one of the things that we now know is that a lot more planning is required to take testing to the next level, okay? If you look at a country like Kenya, we have many laboratories already, about 30, out of which 10 are high throughput laboratories. And yet access to testing is still challenged. If you look into the system, you will see that there are sections of that system that need to be addressed. I'll give you an example in terms of like procurement, getting the commodities to the places where they are required. And the one thing I can say there without fear of contradiction is that perhaps in the future, those who are involved in the business of procurement need to have skin in the game. It can no longer be that those who are procuring are pure procurement agents. They must first and foremost be relevant to the system, and then they become procurement agents. Then they have skin in the game. PCR, as you know, is still very expensive. And unfortunately, the prices have not responded to the demand, as you know, in normal market forces. When we started off, I remember they were around $30, that's something dollars. They are still above $10. If you look at antigen tests that are coming into play, it is conceivable in the near future they could even hit $1. Okay, so that's an important point to note, and especially because antigen tests now seem to have improved since I began validating them. One of my jobs is to evaluate these tests to see whether they work in our environment. Okay, and when I started off, they didn't do so well. And I was charged with advising the government about whether to go the antigen way or not. But now we have come across some of the products that are actually quite relevant and they meet WHO specifications in our hands, in our environment. That's something to think about. And they could be cheap. Now, variants are a big deal. They're a big problem. As you know, in many parts of Africa, now you have variants, UK variant, South African variant, Brazil variant, and I will not be surprised that if we find the Indian variant. The trouble we have is that we are not looking out for them as vigorously as we should. We are not genotyping as much as we should. So it is difficult to tell you whether they are widely spread or not. but we do know that they are there, okay? Because we have found some. And this can be a problem both for, for treatments and for morbidity and mortality, and also for diagnostics. Remember, the PCRs and the antigen tests that we have are targeted at various regions of this virus. And if that region changes, like the spike protein changes a little bit, it is conceivable that a test would not work. Now, luckily for PCR, we don't look at one place. We look at like 3 loci or 2 loci. So by the time a PCR fails completely, perhaps the virus will have changed dramatically, which is not the case. But for antigen tests, we can worry because some of the products that we have are looking at just one section of the virus, okay? So this is important to note. So they may not work, right? So the second thing is that in a country like Kenya, where we can't really afford some of this, we can't spend so much money on one approach, like on diagnostics, and this is or on PCR, and this is the case for many African countries. You have to think about your strategy when you have antigen tests that are available. There are some places that will have high prevalence, there are some places that will have low prevalence, and there are some places that will have intermediate prevalence. And what you need to do is to ask yourself, what are the predictive values of this kind of approach in this place? And should we use antigens, or should we use PCR, or a combination of the both? And luckily for many countries, I note now, including Kenya, the strategic plans around testing have taken this into consideration. Now, coming to the question that you're asking, how can institutions of research, such as the Kenya Medical Research Institute, accelerate easier, effective methodologies for COVID testing? Oh, there are several things that we could do, some of which we've been doing, and other institutions like us have been doing, but there's some we could do better. For instance, the first thing is that we could look at technologies as they become available in the world, evaluate them quickly in our hands, and see whether they work or don't work, and advise appropriately and begin to use them. That's important, because we can't be the only people inventing technologies. There are economies out there that specialize in these things. The second thing, which is critical not only now, but for the future of infectious disease in Africa, is to develop our technologies ourselves from scratch. So build these systems and the infrastructure necessary to develop, and the human resources necessary to develop them. And we don't do this well. That's a fact. We don't do it well. The third thing is to anticipate surprises and prevent them. Like now, these variants of interest and variants of concern are surprises that are being sprung our way. And the way to anticipate them is like to do genotyping regularly, so that when you start seeing something emerging, you're already tweaking the technologies appropriately, or even tweaking the treatments appropriately. We should anticipate surprises. The other thing is that we could look into the factors that prevent access. To be honest, testing technologies exist, and countries like Kenya have spent a lot of money on them. Why does access not look like the dollar that has been spent? There must be some bottlenecks that must be addressed. And one of them, as I said, is the procurement business or the logistics business. And the final thing that I want to say, which I've said at the beginning, is that research institutions have significant assets, including infrastructure, for their normal business that can be turned around or tweaked to fit into a pandemic like COVID. And this is what KEMRI did at the beginning, and this is what other institutions, universities, and research institutions in other parts of Africa did. The equipment they had was relevant even for COVID, and all they needed to do was to change a little bit so they could adjust to this pandemic. I think I'll stop there at this moment, and then later on we can discuss a bit more.
This is actually very valuable information. I'm picking up 5 key points before I bring in the next panelist. Is you should adopt new technologies appropriately and quickly. You also talked about developing our technologies ourselves. Imagine even for vaccine manufacturing, the same discussions. So I think in Africa, this is not a new discussion. I think we're knocking on all the countries' doors. Let's do things in Africa for Africa. Then anticipate surprises. You want to make sure that the people in procurement business have a skin in the game, and they're just not implementers. Very good point. And I like the fact that you talk about the Academia and Research Institute having assets. So Professor Matilumwao, your actual depth in scientific knowledge, we're going to come back to you. about the loci as well that you spoke about. But let me at this point bring in someone who will tell us a little bit more about new technologies, just that you mentioned, and what they have been able to offer to the continent as new technologies to improve access. Please welcome Mr. Mark Matthews, who's joining us from South Africa to give us a run through some innovations and some amazing technology that we could use to make this happen. Mark, welcome to stage. Over to you.
Thank you, Amit. So it's interesting to note that we had a webinar already in July last year on testing, tracking, and treating, and the value of partnerships in the response to COVID-19. And I was a panelist in that webinar. I was reading over some of the discussion points that we had and some of the feedback, and really encouraging to know that a lot of the discussion points that we had already in July last year were relevant in what we're discussing today. But I think today, Amit, I'd like to discuss the program that we've managed to be involved in Africa over the intervening period, some of the learnings from that, and how we are going to be approaching the rest of the pandemic and then beyond the pandemic. So I have prepared a few slides. I'll just take you through them. If we could go to our first slide. So I think really this journey starts before we started focusing on COVID, and we had formed a strategic partnership with the Bill and Melinda Gates Foundation prior to COVID becoming a focal point. And really that was over the course of 2019 to embed our multi-assay platform into primary care systems in Africa and have it as a key enabler to increase access to a number of key assays to deal with some of the larger disease burden programs. So that was our initial focus, and it was really to re-engineer patient pathways and through the provision of access to quality diagnostics, improve the quality of treatment and care for some of our high disease burden programs and conditions. So, when we engaged with KOLs in Africa, what we learned is while there was a lot of dialogue around HIV and TB, there was also a focus on non-communicable diseases. And one of our first programs at the end of 2019 was to launch a program to increase the access to decentralized care for HbA1c to enhance the management and care for diabetes patients. But then, like for a lot of us, COVID interrupted those plans and really gave us an opportunity to fast track our go-to-market strategy and bringing our platform into Africa. So delighted to have the continued support from the Gates Foundation. We were able to partner with the Rockefeller Foundation and MasterCard Foundation, really to expand access to our technology, to allow countries to rapidly scale up their testing. And really, we wanted to focus, Amit, on equitable supply of our technology across Africa. And that was a big challenge for us. We wanted to make our technology available to all 55 countries in the African Union. And that was important to us. We absolutely support the concept of equitable supply. And really, we learned very quickly through this, the value of partnerships. So you mentioned earlier the African Medicine Supply Platform. We've had great support from MSP in fast tracking the access of our technology into countries, looking at the exemption requirements and the country access requirements. That's been expedited through our partnership with African Medicine Supply Platform. And we've had significant support and leadership and governance from the Africa CDC. A lot of the country allocation requirements have been fulfilled from Africa CDC. And we've had support from CHAI as an implementation partner in some of our higher burden countries. And all of this with a focus of making available these 5,000 instruments and just under 2 million COVID antigen tests into Africa across all 55 African countries. And this was really to address the immediate need for scaling up COVID testing while still building the foundations for our longer term plans for long-term primary care infrastructure. So, one thing that we learned very quickly is it's not just about putting more tests into the African environment. It's actually about making sure that we provide more test results back into the health system, and most importantly, getting those results back to the patient. So we focused on making sure, and this was a resolute requirement from us, that the majority of our instruments, and as many as possible, were connected. So obviously data and the connectivity solution that we rolled out into Africa was one of our key focal areas. So the next slide, please. Right, so where we are at the moment is out of those 55 countries, we've received orders from 49 countries, and that's a significant undertaking. It's 90% of our African Union countries. We've to date, and we're talking literally about 5 months into the program, Amit, we've shipped 4,500 instruments and 1.7 million antigen tests to 48 countries. Of those 48 countries, already 30 countries have received their shipments, and 10 countries have started deployment. So we're very excited to see rapid deployment and adoption by these countries. And then we were always aware that the 1.9 million tests as part of that initial donation wouldn't really meet the full requirements of these countries. So we are delighted to have continued support from the Gates Philanthropic Partnership. They've allowed us to subsidize the price of our antigen test down to a nominal price of $2.50. And we are making that available through PFSCM, Partnership for Supply Chain Management, and through AMSP. And that's a contract that we have executed with PFSCM already from the 1st of April. And this will be to meet additional demand beyond that first tranche of donated tests. So allowing countries to continue testing and to maintain sustainable testing programs over the period of requirement. We know that donating tests into Africa isn't going to provide for strong programs. We know that those programs require support. So we've undertaken to hire people in 14 countries across Africa to support both implementation and the programs that follow. And we have an extensive distributor network covering 40 countries. We've also undertaken to form partnerships with local in-country implementing partners and NGOs. And we believe that that will create sustainable long-term program support, which is obviously very important. Over to the next slide, please. So this is a really interesting slide, and we are constantly impressed by the level of innovation and ingenuity displayed by ministries of health. And we don't believe that the technology's innovation is the sum total of the innovation. We're most impressed by the innovative way that our technology is used in these countries. So just a very small sampling of some of the use cases that we see in Africa. We have occupational health screening happening in Nigeria. We have testing in schools in Nigeria, significant mobile outreach into the field in Nigeria. Then we have airport testing. I heard you mentioning earlier, as economies start opening up, the need for testing in airports and ports of entry. So we have significant programs in a number of countries, and Cameroon, Comores, Senegal, just to name a few, where we have testing in ports of entry and airports. And then we have very significant decentralized programs. While we see a lot of our tests being used in district and regional hospitals and healthcare facilities, we also see it decentralized into the furthest reaches of the health system. So level 1, level 2 primary healthcare facilities. Rwanda is a great example of that, where we have our instruments and tests deployed into up to 96 health centers across Rwanda. So next slide, please. So while the current program is centered on the immediate requirement of testing symptomatic patients in high prevalence settings and in high prevalence periods of the epidemiological cycle in these countries, we acknowledge that that's going to change over time. So as we move from symptomatic testing with our antigen test, where it's a one-on-one test, to more preventative screening of potentially asymptomatic patients in low prevalence settings, we have our antigen pool tests. So I'll speak a little bit about that about this full suite of products in a future slide. But really, the pooling test allows us to use up to 5 different swabs into our extraction buffer without sacrificing any performance. And obviously, this increases the throughput as we test with high throughput demands and low prevalence settings. And then we've mentioned in a couple of our previous panelists' discussions the need for screening for vaccine rollout. We have an antibody test, which we believe would, from a surveillance perspective, provide incredibly useful insights into the decision-making around vaccine rollout. And then as we start moving to mass testing, we in the countries that have central laboratory infrastructure, we have a molecular assay that can be used on open systems with very high turnaround time. So what we have here is a suite of products that we believe, as countries move through their epi cycles, have products that are fit for purpose for those different stages. Next slide, please. So just a couple of really quick points on our antigen test. Just a quick couple of comments. It's a high sensitivity immunofluorescence assay. It detects the nuclear capsid protein antigen of SARS-CoV-2, and with its ease of use is perfectly suited to be deployed into point of care settings. We understand that turnaround time is critically important, and I think we've mentioned that in previous discussions. So we have a 12-minute turnaround time from sample application, and this is a point that we see particularly important as we start decentralizing our testing into busy primary healthcare facilities. Then in terms of the swab requirements, we have a nasal swab, and this is really appreciated by our end users. Obviously, compared to nasopharyngeal applications, it's a lot more comfortable for the patients and a lot easier to use. And with that nasal swab application, we have a positive agreement to PCR of 97.6% and a negative agreement of 96.6%. So there've been a couple of comments in previous panelists' discussions around performance. We're delighted to be able to represent the fact that this particular antigen assay has suitable performance, with a limit of detection of 32 TCID50, and then authorized for use within 12 days from symptom onset. So if you could go to the next slide, please. So recognizing, Amit, that 50% of our patients have CTs of above 25, and then 30% measure CTs above 30 on PCR, means that if you don't have an antigen test that is able to detect positives in those low viral load ranges and high CT ranges, you have the potential to miss infections. So, we're particularly pleased to report that our antigen assay has a very high sensitivity right the way up to a CT of 33, so very low viral loads, and then has a 97.6% agreement with PCR right up to the 12-day from symptom onset period. So all of this means that we're able to detect 30% of incremental cases and have a high coverage of all infective individuals. Next slide, please. All of this without sacrificing the ease of use. So we understand that as we decentralize out of central laboratory and out of district hospitals into remote settings, the skill level of our kind of end users needs to have an ease of use, which makes it easy to use in those environments. So incredibly easy to use test, as you can see on the slide. We have a 1-minute sample prep time. It's a nasal swab application that gets inserted into the extraction buffer. The test gets inserted into the instrument. A drop of the extraction buffer gets applied to the test strip. And really after 12 minutes, and it's as easy as this, the report gets displayed on the screen qualitatively as a positive or negative. And then if we have a connected instrument in that environment, it gets linked to our Connect app and is linked either to our HIS, our hospital information system, lab information system, the district health information system, or preferably as well to the patient so that they can have the results as well. Over to the next slide, please. So just a quick couple of comments, and I won't spend too much time on this. We have an antibody test, as I mentioned earlier, similar again to our antigen test, very easy to use, quick turnaround time in 11 minutes. Like with all of our assays, capable of being operated in ambient temperatures. This antibody test uses fingerstick capillary whole blood. And then from after 8 days post a PCR result, we have very good correlation. So 100% positive agreement and 100% negative agreement. So really high performance. And then because our antibody assay detects antibodies to 2 viral regions that are primary targets for neutralizing antibodies, namely the receptor binding domain and the S1 region of the spike protein of the virus, it makes it potentially useful in the detection of post-vaccination antibodies and also neutralizing antibodies. So as we start moving into vaccine rollout, our antibody test is going to be particularly useful in those environments. Over to the next slide, please. And I suppose just a quick moment on those higher throughput molecular system capabilities. We have a molecular assay that has a very fast amplification time, literally 20 minutes, not ours, which when operated on high throughput platforms, open systems throughout Africa, offers up to 5 times of the test throughput on these molecular systems. So I won't spend too much time on that, but I will take you to the next slide, which I believe is particularly important. So when we engage with ministers of health and key decision makers in our countries, the feedback that they get is that they don't want to be investing in another piece of technology. They want to be investing in outcomes. And the best way to prove those health outcomes is evidence-based and to have the data to support those claims. So we believe that this whole discussion needs to be outcomes-based. Having same-day test results that are reported back into health information systems, guiding decision-making is critically important to our current program in the pandemic and also as we move forward into other programs. A lot of our countries have resource constraints, so being able to identify where emerging hotspots are in the countries and being able to allocate resources to those hotspots are particularly important. And as I mentioned earlier, as we decentralize out of central laboratory into decentralized settings, quality oversight and governance is particularly important. So being able to maintain quality oversight over these instruments and end users becomes really an important value proposition. Through our error codes, being able to identify where we're seeing trouble areas and being able to troubleshoot those errors is important. And then obviously all of that enables enhanced post-market surveillance. And then what we find is with our kind of end user and their skill set, we want to minimize the possibility of human error. So the fact that we have connected instruments reduces the risk of human error in data entry. The result gets sent directly to the patient or into the HIS, so there's no transcription error. And we have the ability to integrate, as I mentioned earlier, with the hospital information system, lab information system, into the health information system, but then also to send results into whatever command center the country designates, and also into any particular population health analytics app. And then through our app that we have available to our end users, we are able to send the result back to the patient. So over to the next slide, please. And this is one of my last slides. In our deployment into the fields across the countries that we've deployed into, we encounter not just specific with our programs, but challenges around management and governance. And these challenges range from the fact that we have end users sometimes using point of care tests that have been inadequately trained. There is a proliferation across Africa, as I'm sure we're all aware, of counterfeit tests, tests that sometimes are attempted to be used past the expiry. And then often with visually read tests, there is an opportunity for the test result to be incorrectly interpreted. With transcription error, there's an opportunity for patients to be misidentified. And then oftentimes we see quality control protocols not being adhered to. And then because these instruments are portable, and we see a lot of movement as we see with the use cases that I described earlier, sometimes it's difficult to keep track of these instruments and the tests through the deployment in Africa. Over to the next slide, please. And I'll end with this slide, Amit, and I believe it's really important because a lot of our early discussions have highlighted the need for quality control. We, as part of our implementation process, all of our end users need to be trained on our learning management system, our LMS. And what that does is it qualifies, or at least certifies our end users as being competent and adequately trained in our technology. And they get a username and password that allow them to use the system. If they haven't gone through that training, they can't use the system. So it means that only qualified, trained people can use the instruments. And then once they're actually in the instruments, they have on-screen guidance from step to step. So this doesn't dispense of the old quality reference guide, which we often see stuck to the walls of primary healthcare facilities and clinics across Africa, but it does provide a really intuitive workflow, which is displayed on the instrument. Patient results are tied directly to the patient's unique identifier, which is logged into the system. It also means through our 2D barcode of our strip that there is an automatic detection of the test, which means that you can't use the wrong test for the wrong result. And it also means that we can't use expired tests. So inbuilt quality control processes. That means that by the time we get a result, which is displayed on our screen, that it's a trusted and reliable result. And then we've also had the opportunity to build in quality control alerts, which means that if the end user has specific quality control protocols, that these can be alerted if they're not adhered to. And all of this with a key or core focus of making sure that we have reliable results across Africa. So I'll stop there, Amit, and hand back to you.
Thank you so much, Mark. And like Professor Matilu said earlier, having skin in the game, I think you spelt out the skin. Literally the entire enterprise of Lumira that you've displayed here shows end-to-end investments, not only on simple, effective, but also connectivity that will have data integration. What I'm really more concerned is one of the statements you made, that your platform will also be able to do other tests. And I'm sure we are going to have regular engagements to see how these platforms can be used. Many years ago, we knew about GeneXpert type of platforms for TB, if you remember. And you're now telling us that these platforms are going to expand the number of tests. You also told us about the partners that have given 5,000 instruments. So I really want to thank them. To get 5,000 instruments like this and up to 1.9 million tests, I want to shout out to Rockefeller Foundation, Bill and Melinda Gates Foundation. They've actually made the entry ticket in Africa possible. What we now need to do is to add the numbers. And if the numbers add up and the panelists hear these numbers, it's going to transform affordability for POC testing. I had the privilege of seeing the plant in Scotland, and I was really delighted with the Delta machines and how Lumira was being put in. So hold your thoughts there. There are some questions, Mark, that are on the Q&A chat box that you or Pooja might want to achieve. We'll come back to you. I think after your presentation, Mark, thank you for sharing. It leads to nicely to Dr. Kiran Radia, who's a well-renowned pathologist and running a Kenyan outfit lab, which is affiliated throughout the continent as a respected private sector lab known as PathCare. This private sector lab, Kiran has been in the forefront in working together with government and supplementing government tests in helping more PCR tests out there. So Kiran, I want to welcome you to stage and thank you for joining us and spending time with us. I really want you to share with us your concerns. We all know we want to move ahead with more rapid, quick testing, which is more affordable. And in being a professional in this space, please share with us what you think are the main concerns when it comes to antigen testing, and what is your ask that you'd like the government, your ask to the government to make sure we accelerate this. Ladies and gentlemen, please welcome Dr. Kiran Radia. Over to you, Kiran. Dr. Radia, would you like to go on unmute?
Yes, sorry. I didn't want any disturbance when I was listening to everyone. Thank you. After the policy decisions and what Mark has said about rollout of kits, yes, I think this is the way we will go eventually in Africa, but there are concerns. Now, our government, the Kenyan government, actually sent out testing in a rapid circular on use of antigen rapid diagnostic testing and the guidelines. I'd just like to highlight some of these things. Like you said, what is our ask for the government to make sure we stay with quality? Quality matters. True. You can have a fast producing test. If it's not producing the right test, we have not gained any grounds. So sure. If I can have the same next slide, please. And I've just highlighted what are the things that the WHO guidance came in actually in September 2020 about the COVID. It was realized we need to roll out the COVID antigen test, and they asked us to be cautious. Clinical use should be only in settings where net is available, and I'll mention that because we have to do back-to-back testing of some of them. Where possible, all tests that test positive on rapid antigen test should be confirmed. I think that's changing now as the sensitivities have improved and specificities have improved on COVID. This was, remember, in September 2020. And our most important point was a negative antigen test result cannot completely exclude an active COVID-19 infection. And Mark has mentioned this. The reason, because most of them were not picking up the virus below CT values of 28. As better tests come and we improve the sensitivities, this will be easier. Next. Next, yes. Now, what are the test protocols and what are our, I think the clinicians and the people, the end group will have to come together and actually have their own requirements, how to control the quality. Now, the sample collection is very important. I do not know what the government policy is going to be, but I think it is important that we have trained sample collectors. I would really like to know this, what the policy of the government is going to be, because I know that in some of the places, people do self-collection of the swab. I've done it. And there's no way I'm going to go as far as a professional person who's collecting the sample will go. It's very hard to do self-collection. I think in viral loads, low CT value, this will give you a positive report, but on your own, I think it will be a challenge. Biosafety risks we must look at. Are we allowing just everyone to do the test? It is still a risk factor. So like the government has mentioned in the document, we must test the facilities. We must inspect the facilities which are going to roll out this test, because protection of themselves is important. Then these are easy to perform tests. Like Mark said, we still must have qualified staff who, because it's a manual detection, some of the tests have to do with the manual interpretation, and people who are not qualified enough will definitely give sort of not dependable result. Verification is extremely important, and that has been mentioned by Mark. I won't go into it. The next important thing we're looking for. The next slide, please. Sensitivity, Mark again mentioned. I said most of the preliminary, the earlier tests we saw, the CT value was that was being picked up was quite low. That means the viral load has to be fairly high to have a positive test. Manual interpretation, I mentioned, is very important. That I think with the better technology, we will have the manual interpretation removed and we'll have actually the correct interpretations. False positive, false negative results continue to be a challenge. And there still is a lack of data regarding performance of this test in asymptomatic individuals. And this is very important when we do our surveys of outbreaks. I think this is going to improve as we share data with the whole of Africa on the testing of asymptomatic contacts. Next, please. Now, there are certain groups, and most of the countries, if you see, are actually giving guidelines and how we should use and in what situations we should use the antigen test and screening of symptomatic, and it is usually in semi-closed groups. We heard about the nursing homes, the prisons, the schools, workplaces, dormitories, etc. And we can pick up the early outbreak settings, and there will be a good triage system. We all know what disasters happened in the nursing homes. Regular screening of high-risk groups, healthcare workers, essential workers. I would like that to be emphasized that it is recommended that this should be done frequently, either twice a week or every week on the high-risk groups, the antigen test, just to make sure you pick up the early infection in them. Contact tracing again is good for the symptomatic. Asymptomatic, we really do not know how we're going to pick them up. The high viral counts will be picked, but the lower will be missed on antigen test. Port of entry screening, I think, is questionable. I will wait for policy decision makers to tell us, because you can't afford to have a single mutant coming in if we can test the mutants coming in to the country. So I think the RT is going to be the port of entry regular regulations. Routine screening in schools and workplace, again, the frequency is important to pick up the rates early enough, to pick up the infections and prevent. Next, please. Next. This is just the interpretation. We have the challenges we're going to have with interpretations in high pre-test probability indications, we will draw up our own protocols, and if it is positive, you confirm the infection rate, and if in a high prevalence where there is a focus of outbreak, and if it's negative, you still have to confirm by PCR, still advise them for isolation. Next, and in low prevalence rates like schools and workplaces, it is again a big challenge. I'd like that to be addressed by the policy decision, and I think every country will come up with their own protocols. But finally, I would like to say, what are my asks for the government and the policy makers? Next slide, please. It has to be a controlled rollout of the COVID testing, antigen testing. So sample collection, it has to be controlled. Performance of tests, who's doing it, where are they doing it? Interpretation and documentation of results, important. Verification of the kits. I think Kenya, well, I know in Kenya, that's where I work, there is a fair amount of control on these kits through the Ministry of Health. And sensitivity is higher when viral, I've just mentioned that. Even Mark mentioned this. And I think with time, the sensitivities will increase and specificity will increase, it will be good. Where and when should the test be offered? These are important decisions we have to make. You did mention private-public participation in testing. Yes, we should have pathways of working with the government, and I'm sure we can, in the testing facility site, we can work with them to implement all these quality systems. So this is the user group, I mean, what do we need and how do we interpret the results? Because we are the ones who are then answerable to the patient, to the client. What does it mean? The positive or negative. Thank you.
Wow, Kiran, that was really insightful, and I think all these key nuggets that you have placed will help us move ahead with the kind of policy that we need to make. I want to move to a bit of Q&A and a dialogue session. I have some advanced questions that have been brought in by people from different parts of the world. I'll pick just a few, and then I'll ask everyone to give a parting shot, and then I will close the session, and hopefully we'll have covered this 90 minutes pretty well. It's amazing. This is just the beginning of the Testing Still Matters series. We have 6 sessions happening through the year in different models. We have smaller groups, larger groups. So please save the date as they come. Let me start with Benjamin. I want to pick question 10 from United Kingdom. And many people have joined us from UK in this call. What do you think will be the single most effective policy intervention to ensure widespread uptake of affordable diagnostics? Question number 10, Benjamin, what do you think? Single most. You are the policy man.
Thank you very much. I think the policy is already in place. The policy is already in place, and Africa CDC has embraced, fully embraced the antigen test already. So we have embedded into our continental policy, which is the partnership for accelerated COVID testing. So it is already there. It's just a matter of implementing. That is why we are in the forefront, and we were procuring ourselves and deploy this rapid test in our nation. That we have more than 4 million rapid antigen tests already in so this movement will continue. So we have already embraced the continental policy. It is already there. It's just a matter of implementation, and we need to scale up.
Great. Thanks. The sound was getting a little bit fuzzy, but I think one question from Botswana is also, do you think this common strategy that you're putting in place will be taken up by all African countries as a unified strategy? Is it looking likely?
Exactly. What we, can you hear me now?
Yes, it's much better now.
Okay. No, no, exactly. Whatever we are doing, it is within there is a kind of agreement among all member states. We have the task force in place. We have different working groups in place, and whatever is being decided has a policy, get approval from all member states before we move to implementation. So it is we get the buying of all the stakeholders, all the member states before we move into implementation. It just cannot come out like that. Thank you.
Thank you. I want to bring in Professor Matilu. I want to bundle some questions together, and you see your Kenyan brothers and sisters also sending in. One of the things that's cross-cutting is local manufacturing. Current projects that are progress for local country manufacturing, current capacity to build local initiative for COVID-19 tests. Somebody wants to call it 29, but it'll still be COVID-19. Let's not go into vaccines now. But Professor Matilu, do you think made in Africa tests are possible?
Thank you. Thank you. You'll be surprised, and I'll have to disappoint you about this. You'll be surprised at how easy it is to actually design these technologies. It is that easy, so easy. The issue, of course, is whether they'll be sufficiently accurate or not. That is the research component of it. But making them is very easy. And for instance, where I work at the Kenya Medical Research Institute, we have the capacity to build these technologies like antigen tests or like PCRs. And we have done it before for other organisms. So the issue is not so much whether we can do it or not, but as to whether we can put our heads together to do them, and to do them in a way that is logical for a public health problem like coronavirus. Like, for instance, if it's Kenya Medical Research Institute, you'd have to be doing it with the private sector so that you can put these products out there. The most important thing in the whole of this business is all the time leadership in that area. That's an issue. So, but it's easy.
Great, thank you. Let me bring in Kobile Dlovu. One challenge is faced by users after training. So, when training's done, quality is done, and then upgrades. You've seen some people talking about upgrades done on systems. To keep up the quality, you need something called CPD or CME. What's your view about that?
Thank you so much, Dr. Amit. I 100% agree with you on the issues of continuous learning. I think this is why even the organization like ASLM exists, and also the many other implementing partners that are in this space. It's all about continuous learning. It's all about really staying up to date. So as an organization, we are always on the lookout on the new information that is happening in the space of COVID. And we offer webinars every now and again, just to make sure that people stay up to date. But in addition, we have also created communities around COVID antigen testing. We have what we call multi-country And also now we are launching national, so that whatever new information is developing, we can cascade it even down to the sub-national level. So we are creating a community of sharing best practices, and not only that, even the latest developments. So continuous learning is going to be the thing, because the COVID is evolving, and there's a lot of things that we don't know. We are learning every day, and there's many other organizations that are out there. Everybody is really trying to be sharing the new developments. So I agree with you. Continuous learning will address most of the challenges that most of the trained people will be facing. Over to you.
Thank you, Kobile. I want to bring in Dr. Kiran Radia. There's a business question that I wanted you to try and address before I bring in Mark. And the business question is, PCR now happens in private labs like yours. Expand, buy 10 more machines, 20 more machines, increase the capacity, let it go. Does it make sense in a long-term basis for private laboratories to expand the PCR? What's your view? Do the numbers add up?
No, thank you. Thank you, Amit. Well, as a private laboratory, you have to be careful about the costings and what you can go about in the investment. I agree that I really feel that there will be no place for expansion of the PCR test. PCR test is still going to be the gold standard, but it will be checked against the screening test, which with more sensitive tests that are coming out will take over eventually. And the PCR test, I suppose, will be done by only few laboratories to counter-check some of the findings.
Very, very true. And
it's not going to be a sustainable investment.
And I think today's webinar already is shedding light on the evolution of COVID-19 antigen testing. So I think you will be offering variety. Imagine somebody bought so many PCR machines, they might gather dust, and you might not use them as much as you're using them now. So I think your views are pretty clear. And I want to bring in Mark Matthews here. And Mark, really, one of the questions I want to take, which is offline, is about, somebody asked, do you only test one antigen? I think what they were asking there is, with the new variants coming in and changes and evolution of this virus, will you adapt with tests like the ones that you have to pick those kinds of antigen as well? What's your view about that?
I mean, obviously we need to look at the susceptibility of our antigen test to different variants. And I think we can only go with what we know so far in terms of the tests that we've had performed on the different variants around the world. So we have evidence that we're picking up the UK variant, the Brazil variant. We've currently completed testing with the National Health Laboratory Service in South Africa. It was a very extensive process of testing that confirmed that we picked up both wild type strains from the first wave and also the variants commonly found in South Africa in the second wave. So with that level of confirmation, we know that our test has performed well with all the variants that we've been able to test against. So I think, looking forward, we'd obviously need to assess this on a variant by variant basis, but so far we have success in detecting all the variants.
That is so interesting. Let me thank everyone, and I want to go actually in reverse order from the way we started, and I'll ask the parting shots. Let me start with you, Mark, then I'll go to Kiran, and then I'll ask Kobile Ndlovu, then I'll ask Matilu, and then we'll end up with Benjamin on parting shots for what I consider an important first-time gathering of professionals on a very technical subject. Mark Matthews, the stage is yours for your parting shots.
Thanks, Amit. So my parting shots are going to be more at a high level and programmatically oriented. And I think really the COVID pandemic has exposed challenges in our primary care infrastructure throughout Africa, and also has exposed countries' limited ability to rapidly scale up testing to stop the spread of new infections. But there are a number of key takeaways from our program in Africa and our learnings that I believe are very positive indicators for the management of the rest of the pandemic and for building stronger primary care health systems across Africa, which has always been our founding philosophy at Lemire and the partnerships that we forged with our external partners and our Ministry of Health customers. So some of these key takeaways that I've highlighted are really the strong leadership and governance from Africa CDC, from ASLM, and the leadership and ministries of health across Africa. We've personally benefited directly from this leadership and have seen the success of having strong governance and advocacy from these groups. Then we've seen a unified response across a large number of countries in Africa in the fight against COVID, and also the willingness to collaborate and share best practice and assist other countries in the fight against COVID. And just an anecdote, we even had one country sharing its antigen tests with another country that needed to urgently scale up testing in airports. Now, I mean, we haven't seen that before, but the pandemic and its urgency has brought about a unified response across countries that we see as particularly encouraging. Then we've mentioned it before, AMSP. We have a single source platform for procurement of COVID commodities in Africa. And you need to know that when I speak to my global colleagues, this is something that is greatly admired and revered. The fact is that Africa is one of the few continents that has a single source procurement platform for COVID commodities. And we need to be really proud about that and encouraged about the impact that it's had on bringing product into countries urgently under emergency use. Then we've seen very quick adoption. If we look at the number of countries, obviously I've referenced the fact that we've supplied a large number of countries. We've been able to get that product supplied into countries, through all the exemptions and regulatory processes adopted by ministries of health and quickly deployed into the field for rapid testing, and then also deployed into test settings and use cases that derive maximum impact. So again, key takeaway. And then, as I highlighted with the slide that showed the different use cases, significant ingenuity and creativity and innovation in the use cases, again, to get these tests and instruments, antigen tests and instruments in test settings and use cases, and ultimately closer to the patient, minimizing turnaround time and making sure that we manage these patients as early in the disease process as possible and stop the pandemic in its tracks. So I think a caution, while there's a lot of work to do, and this is not in any way an opportunity for complacency, we need to cycle out of the current pandemic. There is a lot to take out of the learnings of where we are in this program that needs to be replicated for the rest of the program, but then also applied to future program developments. And remember, we have a multi-assay platform. It's going to be embedded in the primary care system of a number of African countries. And as we build out the menu on this platform, I think there's a lot to take out of the current program that we can apply to future program development. Back to you, Amit.
Thank you, Mark. There's a lot. I think this is the message is clear. We are going to carry on engaging all these partners that are obviously very key in taking us to the next level. So, Mark, thank you for your clear parting shot. Let me invite Dr. Kiran Radia. We've had a good engagement with different panelists here. You've brought good insights. Kiran, give us your parting shots. What do you want to tell the attendees and the panelists before we log off this webinar? Kiran, are you on? If you're happy to.
Amit, my parting shot is that as a scientist, I'm amazed at the rapidity of the evolution of the testing and the vaccination in COVID. Historically, as far as I can read, this was not happening ever before. So I'm really amazed, and I hope I'm around to see the results as more and more papers come out and we see the conclusion or effects of all this in the coming years. It's going to be fascinating. I wish I was a PhD student. I would have so much material to write about right now about COVID. And we still are not sure about the antibodies, how we're going to interpret them, the two types of antibodies, the gamma globulins as well as the T cell. I'm sure various companies are looking at it because there's no sense in the antibody interpretation of people who have had COVID. So I'm just waiting. I mean, every scientist is just fascinated as what we're going to find out as time evolves on what we have learned in this 1 year. It's going to be fascinating.
I'm with you. I'm totally with you. This is fascinating. evolution of these rapid things. And we are watching it in our living lives right in front of us. And the Science Council will come up with very interesting new dimensions. Thank you, Kiran. Let me move to Kobile Ndlovu. Kobile from ASLM. I think over to you for your parting shots.
So thank you so much, Dr. Amit. I think my parting shots is just a reflection. Just to say, I believe we are now in a good space than we were before, like early last year. We now have the tools, the innovations, the different diagnostic platforms, including the game changer, the antigen testing. So we do have the tools. So my parting shots now is an appeal to all the stakeholders that we need to move fast. We need to scale up. We need to streamline some of the regulatory processes that sometimes tend to be a barrier in making sure that some of these innovations reach the intended people. So these are just my appeal to all of us as we work together to stop this pandemic. We need to really promote the scale up and wider use of these tools that we have now. Over to you. Thank you.
Thank you, Nkobile. I want to bring in Professor Matilumwao, and you're keeping so busy with all this new evolution, like Kiran says, things are changing fast. I want you to answer one question and then give a parting shot. One question is, there is a tendency of, I think, overcautiousness, and maybe rightly so, by ministries of health, and maybe they are not quick and early adopters. And I think facilitators like yourself can make it more robust in the country. How will you address that? And then thereafter, give us your parting shot.
Thank you. In my experience, especially in the last 1 year around advising the Minister of Health and sitting with other stakeholders, speaking about these problems, has told me that one of the challenges the decision maker, the chief decision maker in the ministry faces, is that they are receiving advice from people who have skills or knowledge, and also people who don't have skills or knowledge who happen to be in the system. And number two, people who have skin in the game and people who don't have. And they struggle a lot. They really struggle a lot to make the final decision. The system must change, and that change cannot come in 1 year or 2 years. For instance, I did notice that many people are interested in tweaking the system in such a way that they'll begin to play the business game. I must say this here, that even people who work in the civil service, the public service, are also interested in commodities and stuff like that. That's too much to handle for a person who is a chief executive in the ministry, and usually they struggle a lot to make decisions. But I would say that perhaps if the system begins to orient itself towards performance, towards merit, and so on, maybe that can change. So that's a very different kind of conversation at another level. But following what I said previously, if you look at procurement, for instance, or commodities, people must have skin in the game. But there's a question that was asked by somebody that I noticed that I would like to just say something about, because it's about, they're worried about variants and so on. What is the false negativity rate for PCR? This is a difficult question, interesting question. It depends on who is challenging your results on the other side. And from my experience in Kenya, especially now that we are interacting with a lot of people traveling to China, the false negativity rate is somewhere between 0% and 13%. On bad days, it can be 5% or more, but usually 1% is acceptable. Okay. Now, in terms of what I would like to say as a parting shot, testing must be taken very seriously going forward. It seems to me as though coronavirus is not going away as quickly as I had hoped last year around June. It seems as though it's evolving into some monster that is really beginning to threaten us very severely. So testing must be really given serious consideration. Two things. One, expanding it to protect ourselves and protect our neighbors and protect other countries around us. And number two, variants must be considered both from a surveillance level and also in the development of the tests. In terms of expanding, we have no choice but to adopt antigen testing in its various forms. we have no choice, and it's our business to find out where it is that we can take antigen tests so that these tests make a difference in our lives. Thank you.
Thank you. Thank you for that percent as well. Such a wide percent, and I think this is sometimes a bit scary. And based on these results, there are some countries around the world that put other countries on the red list, and then we put on the red list. And there's a lot of red list envelope document exchange in the diplomatic circles. So thank you for shedding light on that as well. Let me now invite Benjamin. And Benjamin, you did clearly mention about the fact that you had the pact. We've evolved a lot since last year. You also talked about preventing transmission, preventing death, social harm. We would really love to hear your parting shots and also touch a little bit on movement. People are really happy with the COVID pass and the Africa passport, rapid pass, and those tools that you've created. And I hope it'll become easier, quicker, and also safer. So Benjamin, the floor is yours.
Thank you very much, Amit. And as the continent witnesses the new spike in COVID-19,
Could we try the sound a little bit closer?
let me come closer to my screen.
Yeah, I think that sounds better, Benjamin.
Okay, I was saying that as the continent witnesses new spike in COVID-19 cases and death,
Yes.
what's happening in India, really, we call on member states to prioritize the rollout of antigen tests. Testing as part of an urgent effort to increase national COVID testing capacity and also better manage test positivity rates of less than 5%. That is very critical. Otherwise, it will be extremely difficult for us to get of COVID-19 has COVID-19 stage. And also, even with the availability of the vaccine, really testing remains the backbone of COVID-19 response, providing essential data for decision making by government and all of us as policymakers. That is extremely important. And the only way we can move back or reopening our economy is to rise really the antigen testing. And we are working together with our colleagues, Africa CFTA, the continental the continental trade area. We are working together with them and pilot in some key, land borders to see how best we can deploy these rapid antigen tests in order to reopen the borders. Because in many of our countries, the skies are open, up not the land border, and that is where a lot of traffic and our economies are operating, and that is back well. And that is the reason why we are trying to come up with these innovations of bringing these new tools that you mentioned in order to travel safely and to move our goods and to reopen trade. That is extremely important because for the last 25 years, our economy is going back to recession. So that is something that is extremely bad news for us, and we need to do something about it.
Thank you. Thank you. And I agree we need to do something about it. Ladies and gentlemen, attendees from all over the world, you will agree with me that this very sterling panel has given us so much insight on testing. I may request all the panelists to switch on their cameras now as we do wave the goodbye to all the attendees who joined us. The next test, the next slide, please. I do want to announce as we do move away, this team and many other specialist teams in testing and policy will carry on this dialogue. On the screen, you see the 5th August is the save the date, and we are going to be going beyond the pandemic. I'm sure between now and 5th August, there'll be a lot of evolution, like Kiran mentions, and we shall update you as the attendees, but we shall also talk about how does this strengthen the health system? How will it change life expectancy? And we shall overcome as one continent, one team to victory against this disaster. So bye for now, and we wave together to all of you, and thank you for coming, and asante sana from here in Nairobi. Kwaheri.